Hi, good evening. We're here this evening to discuss the topic of contact tracing. We have here with us this evening Chief Medical Officer Dr. Kenneth George. We also have Mr. Ronald Chapman, who is the head of the COVID monitoring unit. We will also have joining us via Zoom Miss Dr. Leslie Roller. She will discuss the work of the polyclinic in contact tracing. And we will also have Maria Ingram, who is an epidemiologist, who will discuss and give definitions about contact tracing. Over to you, Mr. George.
So thank you so much for giving us again the opportunity to come to the Barbadian public and give an update. We have decided that this update will be on contact tracing. I know there are several other pressing issues surrounding the whole COVID response, but I felt that it would be a good opportunity to deal with contact tracing. You may be aware that within the last 24 hours, we lost 3 individuals to COVID. They were all female. One individual was at Enmore, which is close to the Queen Elizabeth Hospital, and 2 other elderly persons were at one of our nursing homes. COVID is a deadly disease. It affects persons particularly who have comorbidities and who are elderly. And therefore, it is important that in whatever we do, we have a preventative and control strategy for the management of COVID. That's what it's about. So we need, however, the cooperation of all Barbadians in this effort, because this must not be seen ever as a Ministry of Health effort or as a COVID monitoring unit's effort. It is an all of society and all of government effort. Now, contact tracing is an epidemiological discipline wherein we find close contacts of individuals, we identify them, we place them into appropriate care and carry out treatment as necessary. And it is important, this is our main tool we have, other than vaccination, in suppressing this outbreak. Contact tracing is currently done by a team within the Ministry of Health and Wellness that comes out of the polyclinics. So the polyclinics are the gatekeepers of the contact tracing program, and there are several persons associated with it. And Dr. Leslie Rollock will indicate the roles of the polyclinic with respect to contact tracing. But why it is extremely important. We have several forms of contacts. We have primary contacts, we have secondary contacts, and tertiary contacts. Within a framework of community spread, which we do have in Barbados, we are particularly interested in the primary contacts. Those are persons who would have been in contact with the individual who was positive, with a known positive case. And it's like a mushrooming tree. So that if you have a mushroom, you're trying to cut off the different branches in the tree so that the tree does not grow. So you cut off a branch, you start cutting off leaves, and then you go closer to the trunk. And that's how you control the spread of disease. What we know in Barbados, we have seen a new pattern that a lot of the contacts are occurring in families. So we're having cases that there is spread of disease in the community level, but in the household. So you're having persons living in one household and who associate with another household that is close by, who may be affected by COVID, and that is how it is being transmitted. So what the Ministry of Health is attempting to do is yet put another strategy that builds on the seek and save that strengthens the work that Seek and Save has done to again identify those high-risk communities, identify individuals in those high-risk communities who have symptoms, sample a section of the population that do not have symptoms, so we have some form of representation, and get those persons into treatment and care. We have instituted a fairly new program wherein persons who live in certain communities and based on their level of risk, we are bringing them into care and we are bringing them into hotels, designated quarantine hotels. We currently have 40 individuals in our quarantine hotels who have been identified who live in communities that are high risk. So there may be several persons living in that house, and the situation at home may not be ideal. These persons have been brought into our quarantine hotels, and indeed, of those 40, 16 of those individuals have tested positive from a single household. So the message is that COVID, there is community spread, but as you know, today the numbers were 47 individuals. But I would like and let the public of Barbados know that within that 47, that represents several small clusters in families. There's one large cluster and about 4 or 5 smaller clusters within that 47. And we intend to target those individuals and make sure that they are identified early and brought into care. So I will pause at this point in time and ask Dr. Leslie Rollock, who is our Senior Medical Officer of Health, responsible for environmental health, surveillance, and epidemiology, to make a comment of the role of the polyclinics in identifying the contacts.
And try to establish the level of interaction that they may have had with our known case to prepare them for testing and to find where they also may have been. And that way we are trying to get, well, we can't really say get ahead of, but be close behind to where the infection may have reached. The polyclinics are given the cases according to the catchments, the areas where persons live. They using the teams, which may include public health nurses, community health liaison officers, environmental officers, and clinical and medical officers as well. Identify the persons who they may have been in direct contact with, and then where those primary contacts may have gone, where the secondary contacts may be. Invite persons to test and quarantine while they're waiting for their results, so that if they turn out to be positive, they would not have, infected a whole new other set of persons as well.
Thanks. So Leslie, before I ask Ronald to speak, could you give the public of Barbados a simple definition of a contact?
Contacts may occur either, as you had said, directly. So, for example, if I am infected, a person in my household who I would have interacted with for definitely more than 15 minutes within a distance of 3 to 6 feet, that would be the definition of contact. So primary contacts are persons who would have fit that definition. For most persons, they don't measure the way I stand up talking to you 15 minutes without a mask. Most of the interactions within families and relatives and friends are close. So those would be primary contacts. If the primary contact of a case is identified, we don't know whether this primary contact is infected or not as yet, but then the persons who that primary contact would come into contact with, members in their workplace or members in their neighborhood, those other persons that would have come into contact with the primary contact will be secondary contacts of the case. If our primary contacts then become positive, and I hope I'm not confusing anybody, those secondary contacts of the first case are now primary contacts of the primary contact, and so we go on. And the level of contact is determined by our knowledge of the status of the persons that they would have been contacted.
Thanks for that. So I'm going to let Mr. Chapman give, from his perspective. Many of you know that we have employed several persons who are community health liaison officers, and those are part of the team. Those are our foot soldiers in the ground. Those are the persons who will be interacting with people in their communities and within their families. And we ask for your cooperation. We really need the public to come on board. And don't believe that these persons are intruding on their lifestyles, but they are trying to make a bad situation better. So Ronald, I don't know if you want to make a few comments.
I'm just going to shift this stuff around. So good afternoon. So what I want to do is just build on what was said just now. Now, in terms of fighting this disease, it is important that we institute a number of things. One of them is testing. You would have heard early in the outbreak pandemic, the Americans talked about testing, and more testing. So we engage in the testing, and once we've done with the testing, we identify those persons who are positive, and then the persons who are in contact with them. And Dr. Rollock would have mentioned what a contact is. And I just want to go back over it a little bit, because I know that this aspect of our definition is important to business persons and so on, because a lot of persons figure that if you are in a room with somebody who is positive for COVID, now you need to go around and get tested. And that is not the case. For us, and we've been using this definition, it is a World Health Organization definition for contact, for a contact. A contact then is a person who has been in the presence of a COVID case, a positive COVID case, for 15 minutes or more within 6 feet without a mask. So if you fit that bill, then you are a contact. If you do not fit that bill, you are not a contact, and then the Ministry of Health mechanism would not necessarily we wouldn't necessarily go after you in terms of wanting to have you tested and so on. So it is very important that we understand what a contact is, and so that you would know, well, what is a primary contact now? The first person who is in contact, who is associated with the case. So if I'm ill, then the next person who is close to me, who's been interacting with me for more than 15 minutes, less than 6 feet without a mask, those will be primary contacts. And anyone who is now in contact with them will be secondary contacts. So we want to be able to establish that, because we've had a lot of businesses closing. We've had a lot of people taking actions that are not necessarily because they do not understand how the disease is spread. Once we have established that someone is a contact, that those persons then are handed over to the community health liaison officers, to the environmental health officers, to the nurses in the polyclinic, and the medical officers for tracing. Tracing being that they will then take up their telephones, they would call people, and they will ask a series of questions to find out where they are, if they themselves have been experiencing signs and symptoms, and what is a number of other diagnostic questions that helps us to determine their level of risk, their level of exposure, and exactly what intervention we would have to take. Now, this is a painstaking process, and the value of this process lies within the integrity of the person who's answering the question. So if someone is honest with us, then we are able then to get in contact with the person, with other people who they have been associated with. And in that way, we can get a hold of the disease quickly. If persons are less than honest with us, then it makes it a little harder to be able to track down the other people that are involved. The other thing is that we've come across a number of issues. Let me just say this first. For the most part, we've been getting good information. And I want to thank the Barbadian public for that. We have been getting good information. Persons have been very upfront with us. But from time to time, you will get a number of issues. One, persons would have given wrong cell phone numbers, or the cell phones don't work anymore. Sometimes you have persons who have no credit, so our contact tracers would then have to use their own personal phones to call people because they have no credit on their phones, and they can't accept calls from landlines. We've had persons who then would have maybe given wrong addresses or wrong telephone numbers, as I said. And then there are some persons who know that they would have been associated with someone else, but they, for whatever reason, they don't want to say. Because of that, it can really hinder the process. But for the most part, we have been getting good cooperation. I just want to stop here just in case Dr. George want to add.
Ronald, I'm glad you raised that point. There are some human faces to contact tracing, and there are many reasons why people give incorrect information. And but we still encourage the public to cooperate with us, because you may have a relationship outside the family home and you may not come and give us the relevant information. You may give us deliberately wrong numbers and fictitious contact information. That makes the process very, very difficult. We have had to reach out to the Royal Barbados Police Force on too many occasions to rein in persons, which is a public health function and really doesn't have much to do with law enforcement. But we have had to ask them to come and help us along because of the wrong information and the dynamics within households. The final thing I will leave you with before we take questions is that even within households, the way how some households in Barbados is set up is that you have several families living on one portion of land. I would encourage that families from a particular house be careful how you integrate with families from another house, because way too often what we are finding is that multiple households within a particular district are being infected because there's a lot of too much movement of individuals. And I would encourage Barbadians to assist us in this way for the period of time for the next 6 to 8 weeks. Please remain to yourself. Wherever possible, remain on your premises and don't invite people over to your households, because that is how disease spreads. So with those words, I'm willing to take a few questions. Thank you.
Good evening, Dr. George. Mr. Chapman spoke about the contact tracing being painstaking. Do we have enough resources to carry out the work that is necessary?
Well, the ministry has reviewed this process, and we are on the cusp of bringing on 4 additional persons trained either as with masters in public health background or in the field of epidemiology, to add that layer to the Ministry of Health's response. In addition to this, we have scaled up the foot soldiers, the persons in the field who have to go and actually interact with persons on a daily basis. And then we have also identified a team that will do the swabbing. The swabbing will lead to either a rapid antigen test or a full PCR. So usually you have both a rapid antigen test and a PCR test that are used to identify the status of the primary and possibly secondary contacts.
Good afternoon, Dr. George. Barry Allen from the Nation here. Part of this question is a little hypothetical, so I hope you can answer it. These 40 persons that you would have found to be infected and transferred to quarantine approved hotels, are they all new infections?
No. So be careful. This is a method that we are using as a precautionary method. If you're being identified as a primary contact and your housing situation is one that doesn't render you to be able to practice good social distancing, 3 feet apart, doesn't render your ability to, if it only has 1 bathroom and you can't wash your hands as often as before. So these are the real life situations. So it is a measure that the ministry and the government of Barbados has taken. It's a preventative measure. And within that preventative measure, we are still getting persons who are coming up as positive. So I think it's a good measure, and it is here to stay.
So all 40 persons that were necessarily moved were not necessarily infected?
No, that's correct.
Right.
That is correct.
But this is the question I wanted to ask you now. How concerned are you then about asymptomatic infectious persons within these high-risk communities? Do you feel that number could be high?
Absolutely, and we are indeed worried, and that's why I indicated that we are going to be sampling persons in the communities, in high-risk communities, that don't have symptoms, because the only way we could really get a picture of what is happening is not only to target persons who are symptomatic, but to get a flavor within that high-risk zone, only within that high-risk zone, of persons who are asymptomatic and we know they have the potential to transmit disease. That's a difficult question. We ask the public's cooperation. We really do. We encourage the persons to understand the science and make good decisions. But this is why we have press conferences like these, because it is to get the public in a better place. It is to get the public to understand that COVID will be with us for another 12 to probably 18 months, and that we need to be on our guard. We will be in this for the long haul, and these measures need to become run-of-the-mill measures. infection prevention and control, the whole issues have changed tremendously. And even as we look in the future towards welcoming back tourists, it's going to be a total different dynamic, a different paradigm, because we know that we are living in different times. Let me just let you know that we have seen over the past, I would say 2 years, several different infectious diseases. And I believe that this will pass too. But this current COVID environment is one which has stretched the government's ability to respond, the Ministry of Health's ability to respond. And therefore, this is the pandemic that requires a much more greater response from the public at large.
Just a quick follow-up question, Dr. George. Even though the 40 persons are not all infected persons, are they all at least primary contacts?
Yes.
They are all primary contacts?
Yes, that's correct. That is correct.
Dr. George, you want to talk a little bit about the pilot phase 2 Seek and Save?
So we have scaled up. The Seek and Save program had identified about 20 individuals, and the Seek and Save went across several households, 82,000 households in Barbados. But what we have identified is a few hotspots, and that is based on our intelligence. So when I say intelligence, that is what contact tracing surveillance is about. And we have identified those communities, and we're going to be working with those communities. And this is why we require the public's cooperation, so that persons will be coming and asking you a few questions, and in addition to that, we will be offering testing.
Okay, so you may not want to name the hotspots. Can you say about how many hotspots?
11.
We're looking at about 11 hotspots. I don't want to name the hotspots for many reasons, because this is not about pointing fingers. This is about controlling the spread of disease. So we are going to work quietly in these communities. The Ministry of Health has taken on, as I indicated, several staff. This COVID response has been an economic burden to the Ministry of Health. Fortunately, we have had excellent cooperation from all relevant sectors. And I will take this opportunity for the media this afternoon to commit to not only chasing down the salacious stories, but trying to write stories that bring the public, we have the country's interests at heart, and to try to either identify good stories from bad times, or to identify people who have successfully overcome COVID and what people have been doing in their household level to make sure that the spread of disease doesn't occur.
In terms of this particular project with high-risk communities, Dr. George, what is your testing capacity in terms of PCR and rapid antigen?
Well, fortunately, the lab is current as we speak, and once the lab is current, we are in a better place, because if the lab is not current, it affects our ability to transport people and bring them into care quickly. It affects our ability to contact trace. So the lab is currently current, and that has added a greater comfort to the Ministry of Health once the lab is current in our approach.
But how many, can you tell us how many tests would be at your disposal for this project?
So the lab, I will let you know that the lab has a capacity to do 1,500 tests a day, 1,500 and a maximum of up to 2,000. So we are currently not testing as much, and the intention is to bring the numbers up, because that denominator needs to increase. The only way we will be able to get a good feel as to the level of COVID in the population is if we test more. The Prime Minister had told us in the early days that we need to test and test and test, and this is what we intend to do.
Okay, with regards to the nursing home, originally
That is correct.
Okay, and any advice do you have for families who might be fearful because they have somebody at the nursing home?
Right. So thanks for that question. Remember that the individuals affected in the nursing home typically are frail. They typically are in their 80s, and they typically have a lot of chronic disease associated with their in their medical history. These are unfortunate times. COVID has a much higher morbidity and mortality among older folks, and we plan to increase our surveillance of all nursing homes. And that is why we took the unprecedented step that in the first wave of the vaccination program, that we were going to try to reach out to nursing homes and their staffs across Barbados. And we have tried to make that a priority, because these are a set of very vulnerable people, and they need that type of intervention and our type of help.
As a matter of prevention being better than cure, Dr. George, is there a possibility that the ministry may review making all nursing homes isolation, quasi-isolation centers at this stage, so as to protect all these nursing homes from within?
That's difficult. That's ideal, but it's difficult because we don't have the staffing, we don't have the resources. Many of you know that when we have the incidents at the geriatric hospital, we close wards, we move patients to different locations, we move staff to different locations. But not at every point in time I could guarantee that we will have a solution for every nursing home. So the major issue with nursing homes is that they must have their IPC, their infection prevention and control strategies on point, and to make sure that these vulnerable people are taken care of in where they currently are at.
So this unfortunate case of these two elderly people dying at one nursing home, by chance would this be the same nursing home that was isolated?
Yes.
That's correct.
Okay.
One other question from me, Mr. Chapman. I know before we would have had cases at the hospital, cases at the psychiatric, geriatric, cases in the police, cases in the BDS. Has your unit been impacted by COVID?
Yes, my unit has been impacted by COVID. We've had 2 of my officers who have tested positive for COVID, and because of that, there are 1 or 2 other officers who would have been in close proximity to them, who are being tested and who would go into a quarantine. Now, those officers would not be considered contacts because they all wore masks consistently during their duties and interactions. But in an abundance of caution, in terms of giving them a peace of mind, we went ahead and have them tested. So it just lets you know that this, even the COVID-19 monitoring unit is vulnerable to this disease if we are as we interact with one another. Yes?
Question though, Mr.
So
Chapman,
I would just-
have you yet determined if you were 2 personnel who were infected, if they were actually infected off the job or in the course of their duties?
No, this it looks as though it is off the job. Given the dynamics and the interactions that they would have had, it appears to be off the job.
And why we feel that contact tracing will work, let's go back 2 months ago when we had the whole issue in the school. And we were able to identify the risk categories within that school and not just test everyone. The approach to testing everyone whether it be in a workplace or in a facility, goes usually against public health good guidance. We believe that if it is done in a systematic way, you do not need to test everyone, and you can still identify persons at risk. And that is why I would encourage businesses and across Barbados to seek the guidance before you make widespread decisions, either closing your whole property or making decisions based on a process of test all. And then after you have tested everyone, you come to the ministry asking for guidance. Leslie, I don't know if you have anything extra to say with respect to your work in the contact tracing and spearheading the surveillance.
Thank you, Dr. George. Surveillance, so far, surveillance has been to identify areas of infection early. We have been doing surveillance of nursing homes for fever and respiratory symptoms. We have been doing that since the start of the outbreak in Barbados in March last year. We're also doing surveillance for occurrences of fever and other syndromic occurrences, fever and respiratory fever and or what we call undifferentiated fever from persons attending medical facilities across Barbados to be able to have another sign of something happening on the ground, that persons are having infections when they seek medical care. It is not really surprising that the bulk of cases occur in families and communities where there is close mixing because of the nature of the infection and how it is spread with persons, with the interactions that normally happen within a household. We would expect that. So the important thing is to try not to, for families to try not to behave in such a way that they bring infection into the household, which means that the same way that when you go to a business, to cross the threshold of that business, you essentially they check to see if you may be infected with it by looking for signs of fever, but you're also invited to sanitize your hands that you might use to touch things in the business. And we've had a lot of the cases that we've had in businesses, most of the ones that interact with the public, apart from the hospitality sector, have been persons infected or affected in their communities and then bring it into the workplace. So when Dr. George had asked that families try to not mix with other families, what families may need to consider is that when they move from outside to their households, they try to disinfect at the threshold, or the first thing that they do when they come into the house is come in, go and wash their hands. Just from normal going to the supermarket or something else, those that are actually working in high-risk occupations like healthcare tend to do a bit more. They tend to remove their clothing and have one set of thing and bathe and so on and all of that before they interact with their families. But for the average household, it may be enough to disinfect the place, the things that you're contacting the world with, your hands, when you come into your space before you try to hug your children or play with, pick up things and put them in your mouth and that sort of thing. So that the home is usually a safe space where you relax, but and this means that if something comes into the home, it's only your natural immunity that will stop you from getting it inside your household. So you may need to create an entry ritual to try to ensure that you do not bring infection into your home space, then for everybody else in the household to be affected. so that when you go from one part of your family and you have to go to another part, you need to treat them like not family, but like another household whose bubble you may not cross or pierce unless you have disinfected appropriately. And that we may be able to stop the spread between families that do not share the same household. But those are things rituals that not necessarily to be completely separated from your family members in your home, but to try to keep infection out and try to have circumspect interactions with the more frail or vulnerable members of your family. And when you have the opportunity to be vaccinated, go ahead and be vaccinated, but please recognize that you don't get the vaccine today and tomorrow you're immune. So that then you can forget about testing if you've been told that you're in contact, or forget about putting on the mask because you don't believe that you're going to get very sick. We still need to practice the infection prevention control measures to protect other people, even if we don't believe that we need to be protected ourselves.
Thank you. We could take two more. We could take two more questions.
Just one. I know it's a little early, Dr. George. I mean, it's only the third week of vaccination. But can the ministry tell us if there has been any incidences of persons presenting to health facilities with serious side effects or any problems with the vaccination so far?
No, we haven't had any reports of anaphylaxis or severe reactions to the vaccine. The standard things that people complain about: pain at the site of the vaccine, a bit of post-vaccination fever, and just feeling unwell, which usually resolves within 24 hours. I believe the vaccines are safe.
And there have been no hospitalizations, correct?
There have been no hospitalizations. And please remember that we have a system for, it's called AEFI, adverse reactions following immunization, which we track in the Ministry of Health and Wellness.
Thank you.
My final question, we always get the ages for persons when they pass away. You guys don't tell us ages for recovery. What's the oldest person who has recovered, or what are some of the statistics in terms of NCDs that are recovering? Because a lot of those people are saying, you guys just tell us when someone dies of comorbidity, but not when they recover.
Right. So thanks for that question. We could probably do a bit more detailed analysis. The persons who leave quarantine, so for today we had a large amount of persons who have left isolation, and it is a reflection of persons with disease, without disease, persons who have no comorbidities, persons who have comorbidities. So I think it is important, and I think the media should interview persons and see from the person's perspective, what does COVID mean? It may give a different twist, and it may also help the Ministry of Health and the public at large in understanding this ordeal that we face. So I would like to thank again the members of the media for taking the time out to be with us here this afternoon. As we see fit, we have always had a policy where we are extremely upfront, and we will communicate information as quickly and as timely as possible. Thank you so much, and have a good afternoon.